Yes, sir.
Welcome to ENT student for a discussion on standard textbook. What is it giving about the allergic rhinitis? I welcome the student to go forward. Next slide.
Yes, sir.
Yeah, now we are going to give the introduction about allergic rhinitis. What the standard textbook says. We give the courtesy to the standard textbook. Yes, you can start.
Yes, sir. So, allergic rhinitis is characterized by inflammatory changes in the nasal mucosa caused by the exposure to inhaled allergens. It is a common disease affecting between 0.8 to 39.7% of the world population, depending on the location, with prevalence in Western Europe of 23%. It causes significant disability and is often poorly managed.
One of the most important diseases that is, if comes in the top 10, if we take this allergic rhinitis, it has got both inflammatory changes, number one, caused in the mucosa by exposure to inhaled allergens. Allergens are the one which are causing this. It is one of the most common disease. Almost 0.8 and 39.7% of the world population, depending upon the location. Especially in Europe, the percentage given is this much. So you can say almost 40% of the people are suffering from allergic rhinitis. It causes disability adjusted life years, which is often poorly managed. It is not given that much importance. Next.
There may be comorbidities with other organs being involved, commonly to the eyes, causing allergic conjunctivitis and the lungs with allergic asthma. Indeed, these diseases are increasingly considered to be a single entity with a spectrum of respiratory allergic response, termed the unified allergic airway. They have a common epidemiology, pathophysiology, and in many cases, treatment approach.
So how can you say this is a global disease for the body? Is that in eyes it is called as allergic conjunctivitis, in lungs with allergic asthma. For every three asthma patients, for every three allergic rhinitis patient, there is one asthma patient. So 3:1 is the thing that you can remember. When allergy is there, asthma will surely be there. And it is a single entity. You can say that like a rainbow has got a lot of colors. These are the spectrum of respiratory allergic response. Like you have a switch inside the room and then bulb will be outside. When you open the switch, when you put on the switch, the bulb will be glowing. In the same way, allergy in the respiratory channel, it will lead to something called as unified airway disease. If you put a allergen in the nose, there will be wheezing inside the bronchi or in the alveoli. So that is called as unified airway disease. Unified airway disease. So why? Because they all have a common epidemiology. Number one, number two is pathophysiology, and number three, treatment approach is also similar. Next.
Yes, sir. Okay. So, allergic rhinitis and allergic rhinoconjunctivitis are caused by an inflammatory response to an allergen to which the patient has already been exposed. In this abnormal response, the individual has produced allergen specific immunoglobulin E, IgE, which binds to mast cell surface receptors. Subsequent allergen exposure causes this receptor, that is the IgE complex, to trigger mast cell degranulation with the release of preformed mediators.
Kindly pause, please. Yeah, accordingly, so this allergic rhinitis or allergic rhinoconjunctivitis, what we are discussing right now, allergy is the common word, yes or no? And it is an inflammatory response. You should think in an inflammatory response manner only. What is the agent here? It is the allergen for which the patient is exposed. So, what is this allergy actually? It is IgE mediated immunoglobulin response. IgE is going to bind the mast cell. If you imagine IgE as a hero and mast cell as a horse, this hero and comes and sits on the horse called as mast cell. IgE comes and sits on mast cell, and based on which the next time when he comes and sits on the mast cell, when he sees a heroine called as allergen, once again, any dust particle is there, the hero starts running towards the allergen and there is a reaction. That you can say as IgE receptor complex. after which leads to mast cell degranulation. The horse starts vomiting. The horse upon which this IgE and then that heroine is there, that is the mast cell degranulation, it leads to preformed mediators. In that way, you can understand that the horse is the one, that is the mast cell is the one that is going to do all the emesis and that is leading to all the early allergic response. Next.
Mediator release includes not only histamine but also other granular contents, that is like serine, protease, heparin, and newly synthesized icosanoid mediators like leukotriene, C4, prostaglandin D2, thromboxane, and PF. These inflammatory mediators cause the classic symptoms of allergic rhinitis, that is nerve irritation causing sneezing and itching, loss of mucosal integrity causing rhinorrhea, and vascular engorgement causing block. Histamine drives the majority of acute nasal symptoms, such as sneezing and itching, with leukotrienes and prostaglandins being involved in longer term symptoms such as block.
According to this, what we understand is these mediators. I have told you that IgE is there, is the hero, and mast cell is the horse, and allergen is the heroine. So after seeing the allergen, that is the heroine, the hero starts running towards her with the horse. Then what happens? Already preformed, the horse starts vomiting. According to our example, what happens here is that is the histamine. So the emesis of that mast cell has got lot of histamines and other contents like serine proteases, heparin. You can say histamine, proteases, heparin, and newly, these are all the preformed ones, and newly synthesized mediators like leukotrienes, LTC4, PGD2, thromboxane, and platelet activating factor. These are the new ones. Previously, there are histamine, heparin, and serine proteases, his hep and serine proteases, and newly synthesized icosanoid. As you know, these icosanoid mediators like LTC4, PGD2, thromboxane, and platelet activating factors. What happens with these inflammatory mediators? Though the horse starts vomiting, that is the mast cell starts vomiting, and it leads to classical symptoms of allergic rhinitis. Those are the symptoms. What are the symptoms of allergic rhinitis? This is very important for examination. First one, the nerve gets irritated. The nerve is getting irritated. It causes what? Nerve irritation causes what? Sneezing and itching. Most important feature of allergic rhinitis is number one, sneezing. You have to remember sneezing. Number two is itching. Number two is itching. Number three is rhinorrhea. Rhinorrhea. Why rhinorrhea is caused? Because of lack of mucosal integrity. The fluid leaks out like edema in the pathology. In your pathology, you have this edema or not. So that is the rhinorrhea. Number four is the vascular enlargement leading to block. So what you have to have in this particular thing is sneezing, itching, rhinorrhea, blocking. So you can remember it just like that. SIR, sir, sneezing, itching, rhinorrhea. What is sir? Sneezing, itching, rhinorrhea, which is by B, followed by B. So sneezing, itching, rhinorrhea, and blocking. The reasons for which is explained in this particular line. Among which we have already there. So the one which is there already in the mast cell is the histamine. The histamine is there. It drives the majority of acute nasal symptoms such as sneezing and itching with leukotrienes and prostaglandins in a long-term symptom such as block. So what do you understand here? If histamine is the acute reason for all the nasal symptoms, antihistaminics like cetirizine will block these symptoms. You can understand that antihistamines are most important for nasal symptoms which are acute, like sneezing and itching. So this SI is controlled by histamine, whereas leukotrienes and prostaglandins, so and LT are involved in some symptoms such as block. So leukotriene inhibitors and prostaglandin inhibitors. So leukotriene LTC4, D4, and E4 are very important. So which are controlled by, so leukotriene inhibitors are mast cell stabilizers like montelukast. So we give levocetirizine for this early effect and montelukast for this late effect, and also steroid for this late effect.
Of rhinitis. Rhinitis is defined clinically as having two or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, and or itching of the nose during 2 or more consecutive days for more than 1 hour on most days. Allergic rhinitis is diagnosed when these symptoms are caused by allergen exposure, leading to an IgE mediated reaction. Allergic rhinitis is subdivided into intermittent or persistent disease and the severity into mild or moderate or severe, given in figure 91.2.
So as we know, go back please. As
Yes,
we
sir.
know, rhinitis, what is the definition? For every disease, there is a valid definition in the textbook. So what the standard textbook which is giving the definition is two or more of the symptoms. You want two or more of what? First one is rhinorrhea, sneezing, blockage or itching. As we have already seen, you are remembering, sir, sneezing, itching, rhinorrhea and blockage, of which at least SI should be there or RB should be there. So sneezing and itching, number one, and blocking and rhinorrhea, number two. I need two or more symptoms during 2 or more days for more than 1 hour on most days. Two symptoms 2 or more days for more than 1 hour. So you can remember 2, 2, 1. So this is the proper definition of allergic rhinitis. So allergic rhinitis is diagnosed when these symptoms are caused by allergen exposure, which is mediated by IgE. I have given the example already. So IgE is the hero, mast cell is the horse, allergen is the heroine. So you can just remember. So this hero gets on to the horse called as mast cell and goes toward the heroine called as allergen. Allergic rhinitis is subdivided into intermittent allergic rhinitis. What is IAR? It's not AIR, it is IAR, intermittent allergic rhinitis or persistent allergic rhinitis disease, and severity is divided into mild or moderate or severe.
Classification of allergic rhinitis. There are four. There are four: mild, intermittent, persistent, and moderate. So in mild, the symptoms are normal sleep, normal daily activities, normal work and school, and no troublesome symptoms. In intermittent symptoms, it is less than 4 days per week or less than 4 consecutive weeks per year. And in persistent symptoms, it is more than 4 days per week and more than 4 consecutive weeks per year. And in moderate to severe symptoms, there is abnormal sleep, impairment of daily activities like sports and leisure, problems caused at school and work, and troublesome symptoms.
So with this, we are getting an idea. This is almost even for the asthma also. So keep in mind about this mild one. So about this mild one and this intermittent one and persistent one and moderately severe one, moderate to severe ones. So this mild and moderate to severe are two groups, and intermittent and persistent are two groups. So you can, they have got a cross here. So mild persistent it can be, or it can be like a mild, moderate intermittent or moderate persistent, something like that. You can make it as a combination. Mild is sleep normal, daily activities normal, work and school normal, no troublesome. Whenever there is everything normal, no trouble, that is mild one, you can say. And moderate to severe, you can say here sleep is normal, here sleep is abnormal, here activities are normal, here daily activities, sport and leisure are abnormal, here work and school are normal, here problems are caused at work and school, no troublesome symptoms here, here troublesome symptoms. So this is about mild and moderate severe, one or more items. And intermittent, what they say is less than 4 days per week or less than 4 consecutive weeks per year. 4 days per week or 4 consecutive years per weeks per year. And persistent symptoms, you can say more than 4 days per week and more than 4 consecutive weeks per year. So this is like a combination. They also say this in the allergic rhinitis and that impact on life, that is area classification. They call it as area classification. So you can keep it in mind about that.
are not interchangeable with the terms seasonal and perennial and were introduced to relate the patient's symptoms rather than an allergen to a diagnosis. In one large study of people with allergic rhinitis, 10%. Yes, sir. So these definitions are not interchangeable with the term seasonal and perennial and were introduced to relate to patient symptoms rather than an allergen to a diagnosis. In one large study of people with allergic rhinitis, 10% were classified as having mild intermittent rhinitis, 14% mild persistent rhinitis, 17% mild or severe intermittent rhinitis, and 59% mild or severe intermittent rhinitis, persistent rhinitis. Therefore, approximately 75% of patients will be diagnosed as having a persistent rhinitis and 25% intermittent. Whether the disease is classified as mild or moderate or severe depends on the effect of on the patient's social life, work, school, and sleep.
So we have already seen that the last statement, you see once again, mild or moderate or severe depends upon social life, that is sleep, working space, and any problem during his work and his school also. So first part, if you take, definitions are not interchangeable with terms seasonal and perennial. So previously they used to classify allergic rhinitis as seasonal allergic rhinitis, SAR, perennial allergic rhinitis, PAR, and mixed allergic rhinitis, that is MAR. So you used to remember as SPM, seasonal, perennial, and mixed. So both were there, but and are introduced nowadays. So the new terminology which we have dealt is introduced for patient symptoms. So that is for the symptomatology and not the allergen. It is not the etiology, it is symptomatology to get a diagnosis. That is like mild or moderate to severe or intermittent or persistent. Now it is a new terminology. If anybody asks, you should be able to tell. And based on my last study, I'm not going to details of the study, but the end of the day, the statement, therefore, approximately 75% will be diagnosed as having persistent rhinitis and 25% has got intermittent. So in the new terminology in allergic rhinitis is intermittent is 25% people having and 75% people having persistent rhinitis. You can classify as moderately severe, moderate to severe, depending upon already dealt. We have dealt this particular line. Next slide.
Patients with moderate to severe allergic rhinitis and may lead to daytime sleepiness. This is also linked to problems with learning at school and examination success in children and time off work and loss of productivity in adults. Patients with non-allergic rhinitis may have similar symptoms which are discussed in other chapters like infectious rhinitis, occupational rhinitis, drug-induced rhinitis, hormonal rhinitis, irritant rhinitis, tobacco mucositis, persistent non-allergic rhinitis with eosinophilia, and idiopathic vasomotor rhinitis.
So what we have seen here, so the sleep disturbance, because of this nasal block, the patient will not sleep properly. And so what happens is that is based on that only moderate and severe rhinitis can be leading to daytime sleepiness. Especially this excessive daytime sleepiness can be related to your, obstructive sleep apnea syndrome also. So people will be sleeping, and that is related to your Epworth sleepiness scale. Obstructive sleep apnea syndrome will be dealing in the class, of course, and it is linked to problem in learning. So how this allergic rhinitis is very important for children is that allergy leads to adenoid hypertrophy, which leads to otitis media with effusion, which leads to decreased hearing, which leads to decreased in examination success. And even for adults also, during work they can concentrate very less because of allergy related issues, and productivity is less, so their job may be lost if they are not concentrating properly. And what are the other rhinitis, other than allergies? There are many other rhinitis like non-allergic rhinitis, which are discussed in the separate chapters. What are the differential diagnosis of rhinitis if anybody asks? It is because of infection, infectious rhinitis, occupational rhinitis, working in a hot environment like rhinitis sicca, drug-induced rhinitis. So you can have any other. any blockers or any antihypertensives or any other drugs we can lead to rhinitis. Hormonal rhinitis during honeymoon period, especially it is called as honeymoon rhinitis, and irritant rhinitis because of dust and etc. Tobacco mucositis, tobacco related rhinitis, persistent non-allergic rhinitis with eosinophilia syndrome. It is called as non-allergy, but there is eosinophilia. NARIS, it is called as non-allergic rhinitis with eosinophilia syndrome. And the most important for you people, 4 marks or 2 marks question is vasomotor rhinitis, idiopathic vasomotor rhinitis, vasomotor rhinitis.
Getting the allergic symptoms and history with diagnostic tests demonstrating allergen specific immunoglobulin E, whether be skin prick testing or by measuring specific IgE levels in the blood. That is RAST.
What we are going to do? How is the diagnosis being done? We have to correlate the symptomatology, number one. Number two, history. Number three is the diagnostic tests. What are the diagnostic tests for allergy? Or specific IgE. You will write IgE. IgE, serum IgE you will be writing for the patient. And you can go for skin prick test. You take an allergen and prick it in the skin. Take an allergen and prick it in the skin, called as skin prick testing. And measuring the IgE levels in the blood. So you can measure the specific IgE. What is specific IgE? What is IgE? We have seen that IgE is the hero of the story. So IgE, whether that fellow is X or Y or Z, you have a specificity that is done by radio allergosorbent test, as you know, RAST. So IgE in the blood is taken by means of this RAST. So you can just keep it in mind.
Prevalence of allergic rhinitis varies widely around the world. The International Study on Asthma and Allergy in Childhood, that is ISAC 1, and its follow up, ISAC 3, showed the prevalence of rhinoconjunctivitis to vary between zero point 0.8 and 39.7% in different populations,
So
given in figure 91.2.
we have already seen this, like nearly 40%. You can remember what is the prevalence of allergies. Out of every 100%, there are 40 people with allergy. That you can blindly remember like that, 40%.
91.2 prevalence of allergic rhinitis worldwide.
So as you can see in India, let us go for India. It is less than 10%. Most of the times it is green color, and more than 20% in western coast something here, and 10 to 20% in almost Gujarat region, and also Burma and Myanmar region. So especially in India, the prevalence of allergic rhinitis is less than 10% based on this particular picture.
Prevalence of asthma, that is 30%, such as the United Kingdom, Australia, and New Zealand, had a high prevalence of rhinitis, that is 15 to 20%. There has been a steep increase in the prevalence of allergic rhinitis over the last 40 years, though this may now be slowing. The reasons for this increase are uncertain.
So allergens are increasing. We know based on pollution only you can say that. So low prevalence of asthma, that is even the UK, Australia, and New Zealand. These are all cricket teams. As you know, UK, that is England team, Australia team, and New Zealand team. You can just say the prevalence of rhinitis is nearly 20%, and their asthma is 30%. So as you could see here, the steep increase is there. Of course, the reasons are unknown, but you can just say pollution is one of the reasons. Just think like that in a common sense manner.
Children who live on farms and have contact with livestock are less likely to develop allergic rhinitis than their urban peers, suggesting a possible protective effect of microbial exposure. Larger family size, more frequent infections, and unhygiene contact may all be productive. The hygiene hypothesis. This suggests that reduced exposure to infective agents reduce the Th1 response and leads to an overdrive of the Th2 immune response, leading to excessive production of IgE and consequent atopy.
So here you have to keep in mind, people who are very conservative, who will not send their children outside to play, they will have a lot of allergies. People living in the farms, that is in the dust, those who play outside with the livestock are less likely to develop allergic rhinitis. That is called as hygiene hypothesis. The parents are very much sensitive, like latest generation kids. We are saving the kids now from not going outside. That is not good. You should allow the kid to go outside and play in the dust from initial days itself. So what happens is, like in them, the allergic rhinitis is lesser, so less likely to develop in villagers. But in urban people, they are very conservative, so they won't get exposed to the microbes, and that is called as hygiene hypothesis. So whenever there is a large family size, in the previous days there used to be 6 to 7 children in every family. They used to be left out like that. Only infectious diseases were dangerous. Allergy was never dangerous, but now allergy is dangerous. Why? Because this suggests the reduced exposure to infectious agents, Th1 response, and leads to overdrive of Th2 immune response, leading to excessive production of IgE and consequent atopy. So this Th2 is responsible for IgE. So Th2 responsible for IgE and atopy. So when the child goes outside and plays, there will be Th1 response. When the child is inside the home itself, there is Th2 response that leads to more amount of IgE and atopy.
Concept, chronic parasitic disease, for example with worms, is also protective, possibly because of the production of blocking antibodies IgG4. Eradication of worm infestations increases skin reactivity to aeroallergens.
So any concept has got its pros and cons, but there is doubts even about this hygiene hypothesis or this Th2 leading to IgE more in protected children. So chronic parasitic disease like worms, as you know, protective possibly because of the production of blocking antibodies, that is IgG4, and eradication of worm infestation. Once worms are not there, skin reactivity to aeroallergens increases. This is a statement understood.
Organized Western lifestyle promotes the development of allergic disease. The link with helminth infection may also point the way to future treatment options.
So as we know with this, let the child go outside and develop a Th1 response. That is the only one concept. Urbanization is leading to allergy. That is one concept. And helminth infection, as we have seen, if we are eradicating the helminth infection, there is chances for more allergy. That is also one concept. You have to understand this.
Genetic factors are certainly involved in the etiology of allergic rhinitis. Having parents who are atopic may increase the risk of a child having an allergic disease by 3 to 6 times. Exposure to an allergen is also required before sensitivity develops. Therefore, environmental factors are also important.
So very much true for any disease. There is genetic factors and environmental factors. So genetic factors are the etiology, as you know, the risk is 3 to 6 times more in genetic factors. And exposure to allergen is also very important. Environmental factor is also environment. So you can just remember GE like gastroenteritis. G is genetic, E for environmental. So genetic and environmental factor blindly you can write in any disease. So this is easy to remember. And genetically it is 3 to 6 times more prone.
Induced allergic rhinitis is uncommon before the age of 2 years, suggesting that exposure over 2 seasons is required for sensitization. Symptoms of rhinitis generally become less severe with age, and skin prick testing shows less reactivity in the elderly. The atopic march in children refers to the sequential development of allergic diseases, often starting in infants with atopic eczema, then the development of allergic rhinitis, and finally allergic asthma.
So what you have to think here, pollen exposure needs at least 2 seasons. That is very important. Less than 2 years, it is less. And symptoms of rhinitis become less severe with age, and skin prick test shows less reactivity in the elderly. As the age goes on, the skin prick test reaction is lesser. As the age goes on, the skin prick test reaction is lesser. And what is atopic march? That it starts with the development of eczema. Number one is eczema. Number two is allergic rhinitis. Number three is allergic asthma. You have to understand this concept. It starts as an eczema, it promotes towards progresses towards allergic rhinitis, and finally it goes towards the allergic asthma.
Studies have shown that adult onset asthma is more likely to occur in patients with allergic rhinitis than in those without, usually increasing the risk by a factor of 3. Though whether allergic rhinitis is an earlier manifestation of allergic disease in patients who will go on to develop asthma, or whether the nasal disease itself causes asthma is unclear. Remission of symptoms may occur over time. One study showed that although the overall prevalence of allergic rhinitis increased from 12.4% in 1992 to 15% in 2000, in keeping with the worldwide increase, 23.1% of patients who had allergic rhinitis in 1992 no longer had symptoms in 2000.
So this is all about the studies. As you know, that adult onset asthma is likely to occur in allergic rhinitis patients, and usually increasing the risk factor by 3. So allergic rhinitis and asthma, they go hand in hand. Once again, unified airway disease. Whether allergic rhinitis is earlier manifestation of allergic disease, we don't know. As we have seen as allergic march, eczema, it starts as eczema, it goes towards allergic rhinitis, and then finally progresses to asthma. And they develop asthma at the end. We are not clear. It is unclear. So there may be remission also. These are all the examples which they have shown. So nothing much to explain about the examples.
The key points are allergic rhinitis is an IgE mediated disease. In Western societies, it is common, that is more than 20%. It is often associated with other allergic diseases such as allergic conjunctivitis and asthma. It may have significant negative effects on sleep, work, and study. Patients with allergic parents are more likely to be allergic. Lack of helminth infection may be important in development of disease. Allergic disease is often less severe in the elderly.
These are all the key points which we have noted till now. IgE, as you know, just simply the example. Once again, I am giving IgE is the hero, mast cell is the horse, and allergen is the heroine. So hero such as the heroine sitting on the horse. Once the hero sees the heroine, that is IgE, sees this particular allergen sitting on the horse starts vomiting. So horse starts vomiting, it has got a lot of histamine, which is controlled by antihistaminics and other mediators like heparin, etc., etc. That is late formed mediators like leukotriene, C4, D4, and E4, prostaglandins, platelet activating factors, etc., etc., which are controlled by Montelukast, etc. Western societies, it is more common. As you have seen in India, it is less than 10% prevalence and is often associated with allergic diseases like allergic march. We have seen number one is allergic rhinitis, allergic conjunctivitis. Number two is asthma. At the end of the day, it lands into the asthma. The negative effects on sleep, work, and study we have already seen. And patients with allergic parents are likely to develop allergic rhinitis 3 to 6 times more. Genetic and environmental factors we have already seen. And helminth infections are very important, as we have known that helminth infections, if corrected, they may develop the allergies later on. The link of which is being studied. So it is often less severe in the elderly. As you know, skin prick test, it gets decreased and decreased in the elderly patients. So based on all these things, we have got a basic gross idea about this allergic rhinitis.
This will be referred from general practice with two or more symptoms of anterior or posterior rhinorrhea, sneezing, nasal blockage, and itching of the nose. Young children may simply present with block. Other complaints such as itchy eyes, pharyngeal itch, hearing loss due to otitis media with effusion, atopic eczema, asthma, loss of smell, chronic cough, snoring, fatigue, sore throat, and halitosis may occur.
So as we have already seen, all these complaints are not going to details of this. Children may have block and itchy eyes, as you know. Most important is otitis media with effusion. That is very important point. They have less concentration and less listening abilities, less marks in the school, and all these are associated because of allergy. There can be cough, dry cough can be there because of itching and irritation of the posterior pharyngeal wall. There can be snoring and there can be fatigue, as you know, and there can be halitosis, that is foul smelling mouth.
Virulent rhinorrhea, thick post-nasal discharge, epistaxis, pain, and anosmia are not usually associated with allergic rhinitis and should prompt further investigation. The history is crucial. When symptoms started, how long they last, and when they occur will allow determination of likely long-term atopy, whether the problem is persistent or intermittent, and the possible allergens. Ask direct questions regarding symptoms suggestive of asthma, such as wheeze or cough.
So this slide is showing us about unilaterality is not a feature of allergy. Allergy is a generalized disease. Then why only one nose? It involves both the side of the nose. Mucopurulent. When there is purulent component, there is a infection, not allergy. You should keep it in mind. Very thick postnasal discharge. Allergic rhinitis discharge is thin and white color. It's not like watery. You cannot call it as watery. If you say watery, it becomes CSF. Don't say watery in allergic rhinitis. So very important as far as discharge, as far as history taking is concerned. Epistaxis is not at all a feature of allergy. Pain is not feature of allergy, and anosmia also not a feature of allergy. If it is severely congested, if it is severely enlarged turbinates, there can be anosmia, very rarely present. And if these are all present, you have to go for investigation. It's not like simple allergy. You have to keep it in mind. History is very important. Atopy is there or not, you should keep it in mind. Intermittent or persistent, very important. Features suggestive of asthma like wheeze and cough are also very important.
important as it makes the diagnosis of allergy more likely. Symptoms of rhinitis, conjunctivitis, cough, and wheeze during the summer months suggest grass pollen sensitivity. Waking with a blocked nose might be linked to house dust mites in the bed. The main presenting symptoms and their severity should be determined. Thus, the nasal block cause problems with sleep or work.
So as we have seen already, sleep or work disturbances is there. We have to think of it. So now family history of atopy is very important and it is likely to be diagnosis. To have this, once again, atopy is very important. Symptoms, as you know, rhinitis, conjunctivitis, cough, wheezing is there in asthma, and grass pollen sensitivity is very important. And waking with a blocked nose, house dust mites. You have to know the scientific name, Dermatophagoides styronicinus. Dermatophagoides styronicinus is the scientific name of house dust mite. And if you are getting up from the bed and you have got a blocked nose, it is because of bed dust mites. You should keep it in mind. Main presenting symptoms should be important. Nasal block is there or not. Sleep and work is also very important.
So, does the nasal bug cause problems with sleep or work? So, ask about the character of the nasal discharge. A colored discharge suggests infections, whereas the discharge is usually clear in allergy. Thus, the block switch from side to side. This is common in patients with mucosal inflammation and less likely with anatomical abnormalities alone, such as septal deviation. More direct questions should be asked regarding endocrine problems that may cause rhinitis, hypothyroidism, and medications. The combined oral contraceptive pill may cause congestion.
So you should keep in mind about the character of discharge, as you know that. So allergy, the discharge is clear. I already covered this one. And side to side change is there or not, you should say. And inflammation is there or not, you should think of. And anatomical abnormalities like deviated nasal septum. This is of your level. You can say deviated nasal septum also can cause nasal block. You should keep it in mind. And especially this hypothyroidism relates to rhinitis. You have to ask for whether the patient is having hypothyroidism or hyperthyroidism, especially hypothyroidism. And other medications like OC pills, contraceptive pills, and they also can cause congestion. That is very important.
In patients with seasonal symptoms, tree pollen allergy, birch particularly, may be associated with oral allergy syndrome, which causes swelling or tingling of the lips when eating uncooked fruits and vegetables such as potatoes, carrots, cherries, celery, apples, pears, plums, peaches, kiwi, hazelnuts, and apricots, and is found in approximately half of patients with birch pollen sensitivity. It may also be reported with other pollen sensitivities.
So you can keep in mind about specific questions like seasonal symptoms. There is a plant called as birch plant, BIRCH, birch plant. I don't know what is this exactly. I can't say that right now. But when the birch plant pollen sensitivity is there, it is having other cross reactivity such as potatoes, carrots, cherries, especially these kiwis. Okay, peaches, hazelnuts, and apricots. Nowadays, all these things are available in Indian supermarkets also. So most of people are buying this, and some people might have allergies. So patient will come to you sudden nasal block and sudden asthmatic attacks or something like that. You should keep it in mind. And other pollen sensitivities, pollen is based on seasonal things. You should keep it in mind about the pollen sensitivity.
General examination of the patient may reveal other signs of atopic diseases such as eczema or allergic conjunctivitis, and sometimes an allergic crease may be seen on the patient's nose. Examination of the nose should always be performed if only to exclude cause other than allergy. Anterior rhinoscopy will allow an assessment to be made of the color and state of the nasal mucosa and to see whether it is swollen and causing obstruction.
So what you should see in the examination, atopy signs you should know. As we have seen allergic march, it is eczema, number one. Number two, allergic conjunctivitis, you should see. Number three, allergic crease, Darier's line, Denny Morgan fold, they are called as Darier's lines and DARRIER, Darrier line, Dennis Morgan folds. So all around the eyes, and then you should keep it in mind about which is seen on the patient's nose. Allergic crease, allergic salute. So they try to put the hand on the tip of the nose and try to rub it frequently. Try to rub it frequently. That is allergic salute. That is called as allergic salute. Very important for especially the third year students who are going for MBBS exam. They will be asking you. So Darier's line, Denny Morgan folds. You have to refer these things and then keep it in the group. So write down, someone write down Darrier line and Denny Morgan fold, allergic salute. All these things are there in patients with allergic rhinitis. Examination should be done for the nose, and anti-rhinoscopy with the tudicum speculum is very important. And about the color and state of the nasal mucosa and swollen and causing obstruction, whether the obstruction is there or not, you can see. I hope you are, yeah, next slide, please. I hope you are able to follow, importance of this, presentation right now. You're not only reading the standard textbook, but you are able to get some concept when you are examining the patient and all. All these are practical related also. So don't think that you are presenting in a higher level and doing anything bigger from your level. So what always our ex-president Abdul Kalam sir says is, you aim for the stars, at least you will hit the moon. So read in a higher level, you will at least have a basic concept understanding. So especially people, keeping people like me with some experience, you can get glimpse of what you are reading. So not only the regular textbook, always aim for the higher textbooks so that you can have a gross idea of subject. It's not about by hearting. Okay, so you can.
In severe and atypical presentations, especially in the presence of cartilage or mucosal loss, cosmetic changes, systemic illness, or refractory bleeding, exclusion of other inflammatory or neoplastic diseases is important. A history suggesting asthma, such as wheeze or nighttime cough, may necessitate examination of the chest or referral to a respiratory physician.
So you should keep in mind about these things also. Cartilage loss, mucosal loss, cosmetic changes, systemic illness, refractory bleeding, any bleeding is there, and inflammatory neoplastic conditions also very important. So asthma and wheeze, if they are present, coexistent, you have to refer to a chest physician, that is pulmonologist.
Coming to diagnosis, for many patients, a clear history that fits with allergic rhinitis and a corresponding nasal examination will allow a diagnosis to be made confidently. Though in specialist practice, skin prick tests will normally be carried out as a part of a standard workup. If there is diagnostic uncertainty or if the consequences of a possible allergy are important, such as a pet allergy, then allergy testing should be performed. This will normally be either a skin prick test, SPT, or measurement of specific IgE, immunoglobulin E, in the body, in the blood, often referred to as radio allergo, allergosorbent testing or RAST. RAST.
So as we know about this one, history is important. Based on that, you think of allergic rhinitis, you do the examination, you go for the diagnosis, and confidently to make the diagnosis pakka, you have to go for skin prick test, SPT. Remember SPT. SPT is skin prick test. So for example, if a pet allergy is there, if a dog is there and dust on the dog is causing allergen, always you have to test it as a skin prick test. So you can just go for diagnostic uncertainty clearance. You have to clear that by doing the skin prick test. And as you have seen, SPT is one important test, and specific IgE in the blood. For example, for that particular IgE present or not, you have to go for radioallergosorbent test. This we have already seen, SPT and RAST. And SPT, the decrease of this effect in the older people, as you know that.
Skin prick testing is usually the preferred option as it allows the patient to see the results directly and gives time for patient education about avoidance measures if required. The method of skin prick testing involves the use of a small lancet to introduce an allergen into the skin. If the patient is sensitized to the allergen, then IgE sensitized mast cells will degranulate and cause a wheal and flare reaction in the skin.
This is what you read in your second year pathology. Okay. So when skin prick testing, SPT, okay, it is done, it allows the results to be seen directly, and it helps the patient also. So see, you can show it directly as an experiment and then show it as a result for the patient. So it small lancet is used, like you remove the blood in the first year physiology. The small lancet is used to introduce the allergen into the skin, and sensitized allergen, IgE sensitized mast cells. As you know, IgE is our hero, mast cell is the horse, and allergen is the heroine. And the effect is the degranulation of the mast cells leading to wheal and flare. Flare is a red one that is there all around in the skin.
That is saline and positive, that is histamine controls, are also used to rule out dermographism and non-reactivity respectively. If the negative control shows a reaction or the positive control shows no reaction, then blood IgE level should be measured. If an oral antihistamine has been taken in the preceding 7 to 10 days, then the positive control may not react.
So based on this Positive is the histamine. If antihistamine is taken in 7 to 10 days, positive will not be showing. Negative is a saline. So negative is saline to use for dermographism and positive is for non-reactivity. So negative is saline, positive is non-reactivity respectively. So negative is saline, that is dermographism, and positive is histamine, non-reactivity respectively. If the negative control shows a reaction or positive control shows no reaction, then blood IgE level should be measured. So when the negative and positive ones are not showing any reaction, then you have to go for serum IgE. When you have to go for serum IgE, when the negative or positive controls are not showing any reaction, you have to go for serum IgE.
Size 2 mm or greater than the negative control. In the United Kingdom, the main four allergens that should be tested for are grass pollen, house dust mite, cat and dog. But the prevalence of sensitivities varies around the world, with cockroach sensitivity common in tropical countries. Patients with particular exposure can have various other allergens tested depending on their history. For example, exposure to horses or molds.
So we can say 2 millimeters wheel size or greater than the negative control. 2 millimeters, more than 2 millimeters than the negative control. We can say it is a positive reaction. So 2 millimeters is the size that is given here. Grass pollen, house dust mite, I already told you, dermatophagoides, stereonisines, cat and dog, all the very thing important thing. They have got the habit of rearing these cat and dog, okay, fondling these cats and dogs, and especially in India, countries like India, the cockroach sensitivity is also very important. So other tests depending upon the exposure to horses, some people have got habit of horse riding and modes, etc., are also tested.
Shows atopy, but it does not necessarily mean that the patient has a clinical relevant reaction to that allergen. The reaction has to be correlated with the patient's symptoms. Approximately 25% of adults have a positive reaction on skin prick testing, but only 20 to 15% are symptomatic. Though some patients with positive tests will go on to develop allergic diseases in the future.
So as you could see, the clinical relevance is only when the patient has to be correlated with the symptoms and positive testing. So 25% of the adults with positive reaction on skin prick testing, but only 10 to 15% are symptomatic. So almost 10% is the difference between these two. Some patients with positive tests now will develop in the disease in the future. That is also there.
Radioallergosorbent testing is usually reserved for patients who require a diagnosis, but where skin prick testing are unavailable and inappropriate. A blood sample is taken and radio or enzyme labeled anti-IgE is added to the serum. A positive result is shown by an IgE level of 0.35 kil-
Kilo
kilo
unit
units
per liter.
per liter or greater.
So as you could see in the radio, RAST is done when SPT is not available or inappropriate. So this is allowing us to see the Ig, immunoglobulin E in the blood added to the serum, and the level is 0.35 kilo units per kilo units per liter or greater. This is how the measurement is done. More than 0.35 kilo units per liter is important.
Skin prick tests. A positive result may not necessarily be clinically relevant. Nasal allergen challenge is the gold standard of allergy diagnosis, but it is infrequently required or available. It may be useful where the history is suggestive of a particular allergen being responsible for symptoms, but the skin prick tests are negative.
So when you go for this nasal SPT, the positive allergy, as we have already seen, the positive test may not be clinically relevant always. So the 10% discrepancy between the clinical and then the test. Nasal allergen, you put the allergen directly into the nose, that is also a gold standard, but sometimes it is dangerous. But nowadays, not used nowadays. This nasal allergen challenge is not being done. You are directly putting it in the nose and then challenging the nose. So especially useful in the allergy being responsible for symptoms, but skin prick tests are negative. So when skin prick tests are negative, what to do? You have to go for nasal allergic challenge test.
An allergen is applied to the nasal mucosa or the patient exposed to an airborne allergen and subjective measurements made, that is, symptom scores, as well as objective measurements, that is, sneeze count, peak nasal inspiratory flow, rhinomanometry, peak pulmonary peak flow. This method of testing can also be used in patients suspected of having salicylate intolerance using lysine aspirin applied to the nose and is a possible substitute for an oral salicylate challenge. Nasal challenge testing is complex and has the risk of inducing anaphylaxis and is therefore is used only in specialist centers.
So how do you do nasal provocation test or nasal challenge test? You put it on the nasal mucosa like airborne allergen, and you have to go for symptoms assessment. Like symptom scores are there, and there are objective tests. What are the objective tests? Number one is sneeze count. Number two is peak nasal inspiratory flow, sneeze count, peak nasal inspiratory flow. Number three is rhinomanometry. Number four is pulmonary peak flow. So rhinomanometry is the pressure inside the nose. Pulmonary peak flow is pressure inside the particular lungs. And peak nasal inspiratory flow, that is flow in the nose, and sneeze count. So very important. I have put a video of sneezes of a particular allergic rhinitis patient in the ENT student. You can see that. So how allergic rhinitis looks like. This method of testing is also in suspected of salicylate intolerance using lysine aspirin applied to the nose and possible substitute for oral salicylate challenge. So when salicylic acid is having some allergy on the person, you can apply this aspirin and lysine in the nose and then see for it. So these are of dangerous things. Once you put an allergen in the nose, the patient might develop wheezing and die also. So very dangerous, not done in regular centers, to do in specific centers.
Other methods of determining sensitivity are also described, including the measurement of inflammatory mediators such as histamine, prostaglandin D2, leukotrienes, kinins, and tryptase in blood or nasal secretions. Nasal cytology and histology are and measurement of nitric oxide in exhaled air. None of these methods are generally used in clinical practice. Symptoms of asthma may indicate the need for respiratory assessment with pulmonary function tests and reversibility with a bronchodilator.
So other methods, as you know, like inflammatory mediators can be counted, like histamine you can count, PGD2, I said PGD2, E2, C2, D2, E2, like something like that. D2 is very important here. LTC4, D4, E4, leukotrienes are important, kinins are important, tryptase. This is very important. Tryptase counting is very important. It is given in the textbook, standard textbook like that. Nasal cytology, you can say cytology like eosinophil count, you can say, and histology, you can say. So very chronic changes are there, and measurement of nitric oxide in the exhaled air. Exhaled air nitric oxide is also very important sometimes. Of course, these are important experimentally, not for clinical practice, but you can say in detailed discussion. Asthma symptoms need a pulmonary function test and reversibility with a bronchodilator. You have to go for PFT, pulmonary function test for asthma patient, as it is known for everybody.
The history and symptoms are crucial in diagnosis. The timing of symptoms will often lead to diagnosing the allergy. Nasal examination is mainly to exclude other causes. In severe or atypical presentations, especially in the presence of cartilage or mucosal loss, cosmetic changes, systemic illness, or refractory bleeding, exclusion of other inflammatory or neoplastic diseases is important. Ask about asthma symptoms such as wheeze and cough. Skin prick testing is useful, particularly in persistent allergic rhinitis, where the cause may not be clear.
So history and symptoms, any disease very important. Timing of the symptoms important. Examination is important. Atypical presentations in cartilage and mucosal loss. You have to see for cartilage and mucosal loss. You have to see for cosmetic changes. You have to see for systemic illnesses. You have to see for refractory bleedings, and you have to see for inflammatory and neoplastic diseases, and you have to see for asthma symptoms like wheeze and cough. You have to see for skin prick testing, especially long term. So persistent allergy, you have to see for skin prick testing where the cause is not clear. And if that also goes wrong, you have to go for radioallergen sorbent test. And if that also goes wrong, you have to go for nasal provocation test. Next,
Coming to
next slide.
dogs and other furry animals, cockroaches, and bones. Outdoors, the main allergens are airborne pollen, which vary during the year and depend on local conditions.
So reducing the exposure will logically decrease the allergy is one thing, good benefit. And if you think of house dust mite, once again, Dermatophagoides tyronicinus, cat, dog are more common, and other furry animals, cockroaches, especially in tropical countries, and molds. So outdoor allergens like pollen is very important based on local conditions and based on perennial allergic rhinitis.
Europe, tree pollen is found during the spring, grass and weed pollens during the summer, and various mold spores during the summer and autumn. In North America, ragweed sensitivity is a common problem, but this is not found in Europe. Tropical areas will have less seasonal variations.
So in countries like India, less seasonal variation. North America, ragweed is very important. So you have to keep a gap in between these things. Okay, ragweed is very important. Not in Europe, but especially in Europe, as you could see, in spring, and grass and weed in summer months. Okay, pollen is seen in spring and grass and weed in the summer, and sports during the summer and autumn. So sports for summer, as for yes, you can remember like that, and grass and weed for summer, and tree pollen during spring. Spring tree pollen. These are all very important to people who are residing over there, but especially our country, tropical area, less than 10% prevalence, not much of seasonal variation because we have got all seasons similar.
Methods to achieve allergen reduction. House dust mite allergen reduction aims to reduce the amount of mite allergens in the home. It is wash bedding regularly every 1 to 2 weeks at 55 to 60 degrees to kill mites. Washing with cold water removes 90% of mite allergens. Washing at 55 to 60 degrees kills mites.
So as you know, this is very important for anyone. You have to give advice means every 2 weeks you wash the bedding. 60 degrees is needed for this house dust mite. So cold water it removes the allergens, but washing at 60 degrees kill the mites itself. So 60 degrees is you have to remember 60 degrees for house dust mites.
Pillows and duvets in hot water 55 to 60 degrees and encase pillows and mattresses with protective coverings that have a pore size of 6 micrometers or less. Sufficient ventilation of dwellings to decrease humidity. Aim to reduce indoor relative humidity to below 50% and avoid damp housing conditions.
So what you have to do is 60 degrees once again, hot water kills all the dust mites, and 6 microns is very important to encase the pillows and mattresses. 6 microns is very important. 60 degrees, 6 microns. You remember just simply like that. 60 degrees and 6 microns. So ventilation is very important to decrease the humidity. Humidity should not be very much high, and the relative indoor humidity should be below 50%. Avoid damp housing. So 60 degrees, 6 microns, 50% humidity. 60 degrees, 6 microns, and 50% humidity is very important for us.
Strategies. Use a good quality vacuum cleaner if possible, one fitted with a HEPA filter. Use a damp duster when dusting and cleaning surfaces. Replace wall to wall carpets with linoleum or wooden floors which can be wiped clean. Remove or reduce curtains and soft furnishes in the bedroom.
So remove or reduce curtains, soft furnishing in the bedroom. Don't have much of the hangings or curtains in the bedroom. As much as less, you should keep it. And good warm, good quality vacuum cleaner. So HEPA filters is one thing which is used for ICUs. Okay, HEPA filters is very important. You have this idea. And damp duster is important for surface. When you have dampness should be removed. All carpets with linoleum or wooden floors which can be wiped clean. So carpets is better to avoid these wall carpets. Better not to use wall carpets. Next,
Polar
next.
pet allergens is the amount of pet allergen indoors. If possible, find another home for the pet and do not introduce new animals into the home. If the pet is not removed from the home, then exclude pets from bedrooms and if possible, keep pets outdoors. Vacuum carpets, mattresses, and upholstery regularly. Change clothes before going to school or work if you have had contact with any animal. For example, horse or cat or dog.
So all these things can be followed. Get away from the bedrooms. All these pets and all. So vacuum carpets very important, and change the clothes before going home inside the home when you're dwelling with horse or cat or dog. So let them not come into our bedroom.
Cockroach allergen avoidance involves removing the cockroaches, eliminating the places and conditions in which they can live, and removing all allergens. That is, by eradicating cockroaches with appropriate insecticidal bait, seal cracks in floors and ceilings, enclose all food, do not store waste in the home, scrub floors with water and detergent to remove allergens.
So this is how you avoid the cockroaches.
Mold allergen avoidance aims to prevent mold from growing and mold spores from becoming airborne during mold removal. Use dehumidifiers in the home if relative humidity is consistently high, that is above 50%. Ensure heating, ventilation, or air conditioning systems are properly maintained. Use 5% ammonia solution to remove mold from bathrooms and other contaminated surfaces. Replace carpets with hard flooring and replace wallpaper with paint. Repair indoor water damage immediately.
So indoor water should not be avoided, should not be allowed to seepage, and carpets are very important. They have to be replaced, and it's better to have paints. And what is the solution that is used is 5% ammonia for bathrooms. It is better 5% ammonia. And heating, ventilation, and air conditioning systems are maintained properly, and dehumidifiers are very important. So we want the humidity nearly 50%.
Unfortunately, despite these measures, it is very difficult to achieve significant allergen reduction or elimination, and clinical benefit from these strategies has been limited. For example, a study looking at the results of using impermeable covers on mattresses and pillows demonstrated a reduction in dust mite allergen to 30% of the initial level, but found no evidence of clinical benefit. Table 91.1 summarizes the evidence of efficacy for some of these measures. Although evidence base for recommending allergen reduction is poor, it may nevertheless benefit some patients, and a trial of avoidance may be useful.
So we understand that not every time you are 100% successful. All these measures are only a part to control them, not 100% successful. 30% successful that they are telling. Next.
Table 91.1
This
effect
is
of
a
allergen
small
levels and
table, okay,
evidence.
not much of very importance for us, but no, very important to keep, just you have in mind about this house adjustment, how encasing the bedding, washing the bedding at 60 degrees is important. Replace the carpets, acaricides and tannic acid. So like you have to keep in mind about all these things. And then vacuum cleaners with HEPA filter, remove hot wash, freeze the soft toys, and pets also you should get away from the home, keep away, and HEPA filters, washing the pet, replacing the carpets, etc., etc. All these things. Integral HEPA filter also keep in mind.
Food allergy. It is very unusual for food allergy to cause isolated nasal symptoms, although the nose may be involved in more generalized systemic reactions. Foods such as peanuts, nuts, shellfish, fish, and fruits such as strawberry may be involved. Milk and egg allergy is more common in younger children, but usually resolves by 4 to 6 years old.
So milk and eggs should be kept in mind for 4 to 6 years, and food like peanuts, very importantly peanuts, nuts, shellfish, fish and fruits, strawberry should be kept in mind. And there can be symptoms like isolated nasal symptoms to generalized symptoms.
IgE levels can confirm a true allergy but may give false positive results. Therefore, should be targeted at specific allergens rather than having a screening role. Avoidance of allergenic foods may be difficult, particularly in the case of peanut allergen, which may be found in many processed foods. And suitable substitutes must be found to avoid dietary insufficiency and consequent malnutrition. True food allergy should not be confused with oral allergy syndrome, where there is cross reactivity with a pollen allergen and which is relatively common.
So the skin prick test, as you know, Ig levels and skin prick tests, they are not regularly done for a specific allergen. They are not screening tests, but whenever you have a doubt, then only you will be able to do it for even for the food allergy. Okay. Avoidance is very important, and especially the processed foods, you have to avoid them if it is found to be allergy. And true food allergy cannot be confused with, there is some other entity called as oral allergy syndrome, where there is cross reactivity, which is relatively common. So food allergy is different and oral allergy syndrome is different. So with this, we come to an ending of how to manage the allergy and allergic rhinitis and allergy related symptoms. We have dealt a lot about this pathology, and we have dealt a lot about this understanding and how to avoid these allergens. And Restall is the pharmacological treatment which we are going to do in the next video, which you are going to see. This is all from a standard textbook. All the credit goes to the standard textbook, and then which we have to keep in mind when we are treating the patients. And this is how the ENT student will be helping us to understand this one. Thank you very much for watching ENT student about this allergic rhinitis. Keep watching ENT student and have a lot of understanding about the ear, nose, throat, and head and neck diseases.